Morning, paisanos. It's been a while. Another morning chat with your friendly pharmacist. And I'm going to talk about statins because I get asked a lot by people, hey, my doctor recommends that I go on statins. Should I go on statins? So before I get into that, let me just identify my target population for this video because a lot of people have comorbidities. You might have already arterial blockages. You may, you may already have diabetes. You might be a smoker, and that puts you at a higher risk for coronary artery disease and cardiovascular disease. So if you've already indexed in the healthcare system with a physician, you have these comorbidities and your risk is high, you're going to go on it. The questions that I get are usually from people, maybe their 30s, 40s, healthy users who don't have any other conditions except an elevated LDL. And the doctor's like, hey, I think you need to go on a statin. And people are worried about the long-term effects and safety profile of being on a statin for so long. Let's call that exposure time. Usually this medication was given people would develop higher cholesterol or cardiac risk at a later stage in life. So maybe at 60, 70, you'd get a statin, maybe a high blood pressure pill. Now this is happening at the 30 to 40 age. So what that means is, yes, we're seeing diabetes and obesity-related chronic disease at earlier ages, which is very scary and is totally preventable. And people are now getting asked about statins. So first, let me just chat about cholesterol. First of all, cholesterol is just an Uber. It's not like your blood pressure. When it's high, you're at immediate risk, or your blood glucose. Your cholesterol system is a transport system, right? So that's the first thing, and it's been working for a very long time in the human body. So there's some new markers that have come out within cholesterol. There's Lipoprotein A and Lipoprotein B, and I'll link two journals so you can read it. And you'll hear about it, and you can ask for this profile split. When you get your cholesterol panel, you might have to pay a little extra, but you get a Lipoprotein B, which is part of the VL, the very low density lipoprotein, and you can get a Lipoprotein A. There are two different things. But what turns out now, and I had this discussion with my physician and actually just pulled it and confirmed it, lipoprotein A is more of a marker of your genetic risk for coronary artery disease, for building plaque. Lipoprotein B is actually your lifestyle, related to your diet and your lifestyle, and it actually responds to statins. So lipoprotein B is what you can do something about, okay? And the other part of cholesterol is if you have no other comorbidities, one of the things that increases your risk factors actually diabetes or bringing on diabetes. So if you have not a lot of risk factors and you're worried about getting on this, or staying on it, the purpose of this video is to tell you, consider getting a lipoprotein A and B split and observing it. And pay attention to your diabetes. So the second article I want to link, which I want to tell you, is the ability for you to develop plaque is highly linked to the amount of carbohydrates you take in. It's highly linked to the amount of carbohydrates you take in, which stimulates insulin production. So let me first tell you about the plaque development. The lipoprotein A creates an inflammatory condition on the endothelial cells. Once that happens, there's signaling chemicals that draw everything in. So the ideal thing you don't want to have is inflammation in your body or inflammation in your vascular tissue. Nicotine can cause that. High blood pressure could do that. And also, if you're obese and you have a lot of visceral fat, they produce a lot of inflammatory compounds. So you have these things floating around in your system. So does high stress. So that's that's another discussion there. But that's what lipoprotein A does, right? Lipoprotein B actually comes in and acts as like the building blocks, where they get embedded in, and that stimulates red blood cells to come in, and that's how calcium gets layered on. So lipoprotein B adds to the building of it. Now, how does diabetes come in? Well, glucose is shown to be very oxidative on endothelial cells, but also there's a link to insulin. So insulin is good in that it shuttles carbohydrates to skeletal muscle and endothelial cells. But when you eat too much carbohydrates too frequently, your cells become insulin resistant, takes more and more insulin. When that starts happening, you start getting inflammatory conditions and inflammatory compounds being produced on the endothelial cell, which is the insulin is acting on them. So it would appear that insulin actually is related, high amounts of insulin production is related to inflammation in your endothelial cell, which sets up that condition. Insulin as well as glucose will set up that condition, and you already have lipoprotein and VLDLs just going through the pipeline, just as they've done all through your life. So they innocently get caught up in this, and thus plaque develops. So what I would say to you is monitor your carbohydrate intake. I've talked about getting a nutrition tracking app, putting in your metrics and see what your carbohydrate intake is. But try not to have constant insulin stimulation all the time. Try to have longer fasting periods. And I'm going to do another video on eating tips so that you can reduce the glycemic load in your body, so you're not constantly eating. So I would say pay attention to that. These are the things. Diabetes can really drive and is correlated to coronary artery disease and plaque development, okay? A lot of people overlook this. A lot of people focus on the fat and the cholesterol and run to eat low-fat this and low cholesterol that, but you're getting carbohydrates. You really need... Insulin is a storage hormone. We were never designed to constantly have insulin. Insulin secretion is very low in the morning, basal, and picks up in the evening, which means humans were always very active in the day, but in the evening was when we would refeed, and insulin stores everything, and then you go to bed. So this was never, we were never meant to be pounding carbohydrates and snacks. So that needs to be limited. So I would say pay attention to the amount of carbohydrates you eat and the times of the day. Have set feeding times. Don't be snacking on carbohydrates a lot, because you don't want those conditions set up, okay? The other thing about statins I'll tell you is think about life as a risk window. Statins are not evil. They're a tool to help you control your cardiac risk. So when you're 20s, 30s, you probably don't need it. But I will tell you, a low dose statin like Crestor has a better side effect profile. It will drop your LDL, it will drop your lipoprotein B and improve your HDL. So it does have therapeutic effects. The thing is do you want to start taking it early or later? And that's a decision you'll have to make. But what I suggest is, as you start coming to the age of chronic disease, it's like late 30s to 40s now. So by the time you're 50, which is what this channel is geared to, you're kind of well into it. Set up risk windows. Set up a risk window for yourself. And what I do is I have a cardiologist, as I've said before. I get a coronary artery scan every 10 years and an ultrasound every year. So my cardiologist and I assess my cardiac risk. Now, if my blood glucose is good, my HbA1c is good, my visceral fat is getting better, then I could say, well, I probably don't have a lot of inflammation going along. So let's take a look, and you have no blockages in your arteries, so your risk is low. So in fact, my cardiologist never talked to me about statins. I actually insisted on taking it. Do I still take it? Wait till the end. I'll tell you what I'm doing about statins. So I would suggest you do that. And every 10 years, you chat with your cardiologist or assess your cardiac risk, and then you decide with your doctor, do you want to do this with diet or should I go on statins? Sometimes you can do both. But really, I really think that that's a better way to do it, because cardiovascular disease is a time exposure thing, what we call in healthcare. We live to like 70, 80 now. So you have way more exposure time with LDLs floating around, right? And potentially inflammatory decades. You might have decades where your life is carefree. You might have kids, have a career change, and you might have decades where you're so busy you can't eat right, you can't train, you got to worry about the kids, you're stressed out, and your inflammatory risk to your endothelial wall goes up. And this might start causing a little bit of plaque initially, So you need to think of life as windows, because this is how we think of it in drug therapy. And the window for somebody, for me, which is on the 50 to 60 run, is very different to me that's in my 30 to 40 run, So think like that. Don't think, should I be on statins or not? Think of your risk relative to your health status, your weight, your activity level, your diet, and your blood sugar metrics, and your triglycerides, and then assess it. There's no shame in trying a statin, and it's not something that's binary, I'm on it for life or not. And let me take you to what I do. I did start a statin. I asked my physician for it, my cardiologist. Like I said, he didn't really suggest it, but he's like, hey, I write you the script. You made a case for it, because I told him, check my lipoprotein. It was elevated. I'm like, I want to get that down. So he said, all right, try it. And then we'll come back and see. But my other panels were fine. My cardiac risk was 0. So I did take it, and it did help. My lipoprotein B went within range. My HDL was always good, but I get an avocado a day, and in our family, thanks to my mom, we have high HDL, so that was good. But your body needs cholesterol and as a transport for fats to build cell walls for brain tissue, neurological tissue, and for hormones and sex hormones and all the hormones that control your body. So I decided I was going to take a break from it, and I de-seeded. Now, there are options with that. If you're kind of on the fence, you're not too sure, you could try to make some lifestyle changes and see if it improves your profile. What I did sometimes, I did a drug holiday. I'd take it for 3 months, cycle it off for a while, and get back on. That's one thing. If you get a lot of muscle cramps or your liver enzymes go up. But the other thing you can do is you can take a break from it. You can take it for a year, get a profile, and if you made lifestyle intervention changes, before your next yearly labs, you can tell your doctor, look, I'm going to cycle off of it for 2 or 3 months. Let's pull the labs and see where I'm at with my diet. Like, do I still need this to control my cholesterol, or have I brought this down? So that's an option. You can play with it. You should never come off your blood pressure meds, never come off your glucose meds. But there are things you can do to ameliorate your cholesterol level, and you can kind of throttle it to see. Now, like I said, if you have comorbidities, I don't recommend this. But if you're generally healthy, very low cardiac risk, you can kind of I've been on and off of them for years but I routinely change my diet as well, So that's my advice on statins. And like I said, don't think of it as good or evil. It's a tool for you to use as your cardiac risk changes, and work with your doctor to assess, but be honest with yourself about that, and don't shy away from it, because if you do have plaque development, you don't want to not prevent those things from coming on. But remember, cardiac disease is an inflammatory disease, so you need to be tackling that head on. The LDLs are just the guys who are floating along and get throttled in there. You should be doing things to reduce your inflammation and try to figure out why your liver is producing these, okay? So, okay, have a great day.